Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is atopic eczema. Atopic eczema is a chronically relapsing, itchy, inflammatory skin condition often associated with other atopic conditions such as asthma and hay fever. It has polygenic inheritance. The male to female ratio is approximately equal, and eczema is known to affect approximately 10% of children by the age of 7 years, so it's not an uncommon condition. 70% of cases have a positive family history. The pathogenesis of atopic eczema is an active area of research which is not fully understood. However, it is known that an antigen activates Th2 T helper cells, which goes on to produce IL-4 and IL-5, stimulating B-cell IgE synthesis. Signs and symptoms are quite characteristic of atopic eczema and multiple in number. It can involve pruritus, macular erythema papules, or vesicles. Lichenification is also characteristic of this condition, as well as excoriation and xerosis. Impetigonized eczema, secondary to bacterial infection, may occur. Follicular eczema is particularly prevalent in African Caribbean populations. The distribution of eczema may be quite varied. In infants, it tends to be on exposed areas, whereas in children and adults, it tends to affect the flexor areas. Conditions associated with eczema include asthma, hay fever, and other allergies, including those to food. Anaphylaxis is also associated with eczema. Investigations primarily involve a clinical diagnosis, but a skin swab can be conducted if suspecting a secondary infection. Raised IgE may be seen, and a positive radioallergosorbent or RAST test or skin prick test will support a diagnosis of atopy. Treatment primarily involves identifying and avoiding triggers, such as soaps and detergents. It's important to reduce house dust mite exposure and also treat any secondary infections. In terms of medication treatment, emollients or topical steroids are the first line of treatment. In more moderate cases, topical immune modulatory drugs such as tacrolimus may be required. And if it is severe, patients may require UV therapy, oral steroids, or second-line immunosuppression, for example with azathioprine or cyclosporin. Complications of eczema can occur, most commonly secondary bacterial infections, usually due to staph or strep. Herpes simplex can also complicate eczema, causing eczema hepaticum. The prognosis of eczema is usually quite good and improves through childhood. However, half of patients do have persisting symptoms beyond 13 years, and half become symptom-free by this point. So now going on to some questions. An 18-year-old man presents with itchy erythematous plaques over his antecubital fossa. There is associated excoriation and pus-like discharge from the surrounding skin. A diagnosis of eczema with secondary bacterial infection is made. What is the most likely causative organism? So our options are Strep bovis, Staph aureus, Neisseria gonococcus, Strep pneumonia, and E. coli. And you'll remember that Staph aureus is the most common causative organism for this particular presentation. Question 2. A 40-year-old lady with a known history of asthma and eczema presents with worsening erythematous rash over her face and flexor areas. She has had a trial of topical steroids and emollients previously. Which of the following is the next most appropriate management option for this lady? So our options are oral steroids, oral antibiotics, topical immune modulatory drugs, avoiding irritant soaps, and cyclosporin. And the correct answer in this case is option 3, topical immune modulatory drugs. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.